I'm going to introduce our wonderful speaker, Dr. Christine Brezden-Masley. She is a medical oncologist and the director of the Marvelle Koffler Breast Centre at Mount Sinai Hospital. And she's also the medical director of the cancer program for Sinai Health in Toronto, Canada. And she is one of those super smart, smarty pants people who did her PhD in medical biophysics before doing her MD. She's an associate professor at U of T. She's a highly respected senior scientist, and she presents at many international conferences. I've had the pleasure of hearing her present at some of them. She's on many advisory boards, she chairs meetings, she's on peer review committees. She also does a ton of important research herself, and she's very involved in promoting clinical trials. She's also the mother of twins. And on top of that, she finds time to really give back to charities. She's on the board of My Gut Feeling, which is for stomach cancer. And we are so, so lucky to have her on the board of Rethink Breast Cancer. She's been involved for many years and just always there to guide us and help us with questions. And, you know, on top of all of this, she has many, many, many patients. She has a very robust, busy practice. And what we've learned, and it does not surprise me, is her patients love her. We've had so many lovely comments just in setting up this and promoting this opportunity. And so basically, like a pretty darn awesome person who's taking time on her Saturday to help us get this information out to you and just be here to kind of support and clear confusion. So I want to start, Dr. Brezden, by just saying hi and just kind of really a very broad way of setting the tone, like, how are you and how has it been the last, I guess, 6 to 8 weeks at the hospital?
Hi, everyone. Thanks for joining this great Zoom meeting. I have had many Zoom meetings, so we've all become Zoom experts. Thanks, MJ, for inviting me, and Shauna for organizing this. And it's nice to see all your smiling faces. I see some of you are videoed out, but that's okay. The hospital has changed significantly. I can say the first week when the global pandemic was actually announced, you know, Sinai and many other hospitals were already looking at how we are going to plan and phase through the pandemic. And this actually started happening in January, because we were all aware that this virus was out there. China was hit, obviously, first, as you know, and then Europe was hit. So this has been planning for some time. And just living at Sinai now, you know, going into clinic, we have changed significantly, and we'll talk a little bit more about that. MJ is going to have some questions about how we've changed our practice. But it's really a ghost town. Every hospital now is a ghost town. You have to really be pre-screened prior to coming into the hospital. We want to make sure that patients are safe, that individuals are safe, that the healthcare workers are safe. So the first couple of weeks when this all happened, it was chaos, I think, because honestly, on an hour-by-hour basis, things were changing. Can you guys hear me, by the way?
Yes, perfectly.
So by hour, things were changing pretty quickly. And I don't know if you remember, but it was the week that I was supposed to be in Colombia on our March break. And so we got canceled, obviously, thank goodness we canceled everything, because I probably wouldn't be here. I'd probably be stuck in India. But we changed everything. And so that first week, as I said, was, honestly, it was hour by hour. Things were changing rapidly, and they continue to change. We work very closely with IPAC, which is the Infection Prevention and Control. And every hospital has an IPAC lead, an IPAC group. And we work with infectious diseases and obviously with the executive. So with us in oncology, we are the only full ambulatory clinic running in the entire hospital. So every other clinic has really either closed or is running on minimal kind of entrance and staff, where we still have our full staffing cohort. So that's at Sinai. We're still really the only full ambulatory clinic, which means you're coming into clinic for some patients who are receiving active therapy, and we're continuing with active therapy. but of course, social, physical distancing is a big issue, masking
Mhm.
patients, and COVID testing patients as well. So we can talk about that. Needless to say, it's hard. I like to hug my patients, as some of you know, and I'm wearing scrubs and mask, and we really don't touch patients unless we have to examine patients. So it's a lot of infection control on everyone.
Wow. Thank you for just sort of painting a picture of what it's been like. And I know your hugs because you're just such a warm person. So I imagine that's really hard. Let's maybe start with kind of backing up and just really explaining why cancer patients are at such an increased risk for COVID-19 infection. Like why do we need to protect them especially?
Yeah, so what we've looked at and seen in terms of our vulnerable population, as you know, the elderly are vulnerable, and we've seen this for decades.
Mhm.
With when the influenza hits, our patients unfortunately pass away, and they're usually the elderly. Cancer patients who are on active therapy, so usually active chemotherapy. So if you're on hormonal therapy only, you're not at any increased risk. But if you're on active chemotherapy and you are obviously somewhat immunosuppressed, and so what we were concerned about is that cancer patients, either who've had recent surgery, so large surgeries, or are on active chemotherapy, are really truly the vulnerable population, and these are the patients that we have to protect. And make sure that we try to keep them safe, either in hospital, and educate them even at home, how to ensure that they minimize the spread, actually the infection, to themselves and to others. That being said, you'll see at different institutions different kind of criteria. So some institutions, for every new chemotherapy start, you will be required to have a COVID test. We have not, even if you're asymptomatic, you're feeling fine, you need to start chemotherapy, we have not instituted that yet at Mount Sinai Hospital. But we're working with Cancer Care Ontario, which is now Ontario Health, and as I said, our IPAC. So every institution's different, but about, I'd say 50% are requesting a COVID test prior to starting chemotherapy. But then, your COVID test, you can become positive during chemotherapy. So it's, we just want to follow symptoms and follow the patient. So as I said, patients who are elderly are at risk, active chemotherapy if they're more immunosuppressed.
So I think that, thank you. I think a question we've heard from our women in our network is, we all know now that cancer treatment doesn't necessarily end with ringing that bell or whatever, that there's ongoing treatments, especially for our young women in the community. So how long does that immunosuppression piece last? Is it a sliding scale? Are you only really considered immunosuppressed when you're in active chemotherapy, or do the follow-up treatments impact things? And of course, I also think of our metastatic women who are in ongoing treatment.
Yeah, so in terms of active chemotherapy, typically when you look, active chemotherapy patients, some of them are receiving something known as GCSF support. So it's either Lapelga, Grastafil, Neupogen, Neulasta. So this is really the immune boosters that we talk about. And so that really protects you from bacterial infections, right? So your white blood cells, it's an army of different cells that help fight certain infections. Those typically will help fight the neutrophils, help fight bacterial infections. The lymphocytes are the ones that kind of help fight viral infections, and coronavirus is a virus. It's a viral infection. So a little bit different. So typically the white blood cells for active cancer patient hits the bottom 7 to 10 days after chemotherapy, and then rebounds after that, because that's a normal immune system that then starts rebounding. We are built with a regenerative bone marrow, so that actually regenerates itself. So typically by 2 to 3 weeks, you're theoretically back to normal, right? So back to where your bone marrow is. So that kind of does help, in terms of normalizing your risk. But we've noticed this virus is very different. it can attack very healthy individuals. You know, the highest risk obviously are the elderly population, anybody with lung issues as well. You've heard asthma. We worry if our cancer patients have lung metastases and are symptomatic. So this is the issue in terms of ensuring that our patients are more protected.
Okay, great. Thank you for that. I'm just seeing a question pop up in the chat, and it is from someone who's living with MBC and just wants to know, is there a benefit, she's asking, is there a benefit to know if I've had a previous COVID infection? And if so, would she need to advocate for herself to get antibody testing when it becomes available in Canada?
Yeah, so if you've already been infected with COVID and you've recovered, theoretically, you should already be immune to it. So, I mean, you can have your antibodies tested when it does become available, but by all viral, you know, infections that we've had before, we tend to build the army of our lymphocytes to help fight future infections. Again, we're still learning with coronavirus. You know, if patients are positive on active chemo, we have requested through the guidance of Cancer Care Ontario, so I'll call it Cancer Care Ontario, I know it's called Ontario Health, through Cancer Care Ontario for us in Ontario, and of course this is across Canada, and it's pretty similar, I would say, across Canada, that we need to have 2 negative COVID swabs. And these swabs are very painful. If anybody's had a nasopharyngeal swab, you'll feel like you're being drilled in your nose.
Just seeing the illustration was enough for me. I didn't need to.
So having a COVID swab is very uncomfortable, and our patients are succumb to having 2 negative COVID swabs before we restart chemotherapy or start chemotherapy. And those swabs have to be separated by at least 24 hours. So it is a lot of onus on the patient to come into the hospital and get your swab. The great thing now that we've become very fast in getting our results. You've heard, you know, backlogs of 7 days, 10 days. Now we're typically getting them within 24 hours.
Wow. Well, that answer just about the pause in treatment kind of leads me to a question that, of course, has been top of mind for our community and any cancer patient out there, whether it's a delay in surgery for a newly diagnosed patient or just a pause in treatment. Can you speak to just the triage process? And of course, patients want to know, okay, triage, clinically safe, for sure, clinically safe. How do we know? What's the long-term impact of any of these delays going to be? Answer that as best you can.
Yeah, so I mean, that has been top of our you know, strategy, our strategic plan since the beginning. What is the risk of having surgery? So first of all, if I look at besides breast cancer, I will focus on breast cancer. But you can imagine, you know, having a large colorectal cancer removed. Some patients have to go into the ICU or they're in the hospital for 3 to 5 days. So the whole point of trying to safely, and this is all individualized, trying to safely hold certain surgeries, delay them. So delay them. And by the way, we're opening up. Delaying surgeries was because of the fact that we were anticipating a huge surge of COVID positive patients. And we fortunately have not seen that, which means we can start opening up. Breast surgery, so at Sinai, they are, and it's all been strategically put forward, that are opening up, and certain surgeries are ongoing. So if we just talk about surgeries and new diagnoses. We've triaged women who received neoadjuvant chemotherapy, that those women would be the first in line to go for surgery, because these were timed, you know, tumors that were treated, and so these women were first to go to have surgery. Remember, 75% of breast cancers are driven by estrogen, and you know, women do tend to wait 2-4 weeks to have breast cancer surgery, and we've just done that because we feel that we have the capacity to do a breast surgery. typically they're not rapidly growing tumors. These are slow growing tumors. So what we've actually done, and very safely, is seen these patients. So the medical oncologists have seen these patients, these new diagnoses, and have started anti-estrogen therapy to bridge these women prior to their surgery, and very safely. And we've discussed all these patients that are Zoomed, or we use OTN. So we've discussed all these patients at our tumor boards, where you have the surgeons, radiologists, pathologists, oncologists, like the whole team discussing these cases. And we've actually flagged where we have delayed women having their surgery as a COVID, right, due to COVID. And so we're capturing all that data. So we will have information on the safety of delaying some of these surgeries. Now, it's still individualistic to every cancer patient. So these are new diagnoses of cancers. I think what has been concerning for some women is my mammograms are being delayed, right? All my imaging is being delayed. So once again, it's been a safe approach, because you can imagine we can't flood the mammogram center. First of all, social distancing is a huge issue. Patients don't want to come to the hospital if they don't have to. So we've been, once again, individualistically looking at our cancer patients with a previous cancer diagnosis and are in survivorship, safely trying to delay some of their mammograms if we can. But mammograms are still running. Everything's been significantly downplayed, right? So obviously it's very individualistic. If a woman has a concerning breast lesion, obviously get in touch. Family doctors, we're providing a lot more virtual care. So this is something that has also shifted how we're delivering care. Our active treatments are coming in the morning. In the afternoon, I'm basically on the phone through OTN, so with Ontario, with their telehealth, providing virtual telehealth, telephone consultations and follow-ups. And so that is actually across the country that we've actually moved into this virtual version of cancer care. So I think safely delaying surgery, we will capture those answers in terms of the safety. We feel that there's safety now. A triple negative, rapidly growing breast cancer. These are patients we're gonna see in clinic and probably start chemo on. Metastatic patients, if they can safely be delayed, patients who are on, for example, a CDK4/6 inhibitor. Yes, they're a little bit immunosuppressed, so obviously be careful. But some of them, if they're in, maintenance phase, and it's safe to delay coming into clinic for 4 to 6 weeks. So it's very individualistic, and we've, many of the oncologists have been all working together to try to provide, safe care to our cancer patients.
Thank you for that. And I know so much of what the community goes through, it is emotional. And as you said, everyone's individual. And it's a bizarre situation, because on the one hand, if you have been triaged and things are being delayed, that typically would mean it's because your cancer isn't as serious. So that's kind of a good thing that you fall into that category. However, it's still stressful.
Of course.
Versus if you're going forward, it's kind of a sign that, okay, we got to treat you even in a pandemic. So it's been kind of an interesting situation for our community to get their heads around. Are you finding, you're obviously with these tumor boards and Zoom meetings, and it's kind of nice to know from the patient perspective that everything's really being looked closely at. How about the communication back to the patients? Do you find you're having the time to reassure, like you are such a compassionate oncologist? Do you have that kind of time, or has that been a change for you as well?
Yeah, so when we do our virtual consultations for the first time, when we're suggesting anti-estrogen therapy to bridge before our surgery, this is, we spend a lot of time talking about kind of what a breast cancer is, what type of breast cancer that patient has, and the fact that it is quite safe to start anti-estrogen therapy with the view of having surgery whenever surgery opens up. So It's actually opening up a lot earlier than we anticipated. So we're kind of looking September, October. But some sites are already opening up for breast surgeries. But certainly, of course, it's very, women, anybody diagnosed with cancer is very anxious. This is a a diagnosis that changes everyone's lives, as everybody on this meeting knows, right? It changes everyone's lives. And so by educating our patients, having conversations with them, spending the time, it, I think, decreases the fear and the anxiety a little bit, knowing that everyone's working together, right? So a big piece is the chemo or the treatment piece for the medical oncologists. Surgical oncologists are trying to arrange their surgeries, and don't forget the radiation oncologists, right? So we are linked with Princess Margaret Hospital, but certainly radiation has still been going on, and women are being treated. But if we're delaying surgery, we're going to delay the radiation piece. So things are just delayed. And what we're trying to ensure is that once this pandemic clears, and this will happen, this day will come, that our backlog won't be too significant, right? It's how do we face? So we're even looking at, treatments on weekends, having clinics run on the weekend, longer hours. These are some of our strategic plans that we're putting forward to try to ensure that we provide the support for our cancer patients.
That's excellent. Yeah, that's really good to hear. Why don't we go to some of the questions? Shauna, did you want to highlight anything for me? I can see a whole bunch of questions. Anything you want me to give a special shout out to? Let's see. Someone has a good question. Any thoughts on accessing lymphedema sleeves right now with fitters closed? This is a significant challenge. I don't know if that's something you can really speak to as an oncologist, but.
Well, I mean, there's some quick fixes at home, which I tell some of my patients. I mean, that some of the dollar stores are still open. Pharmacies are open, but you could buy a tensor, right? So you could just do a quick fix while you wait. It's like people with their, not the same, but nails and hair and other things. but you can certainly do a quick fix by taking your hand and just wrapping the sleeve, making your own actual sleeve with a tensor bandage. That has worked actually very well for many of our patients. And don't forget massaging, right? Massaging, milking that fluid up into the axilla, into the armpit. That's very, very important. So these are some quick fixes that you can do when until these clinics reopen.
Okay, great. Here's another question. For those on tamoxifen, there's a risk of blood clots. Does this only apply to people who are at risk of does this only apply to people who are already at risk of getting blood clots, or can this apply to anyone? If it can apply to anyone, given that severe cases of COVID can have blood clot complications, is there a higher risk of this complication for women on tamoxifen?
Yeah, so that's a good question. Tamoxifen does have that risk. It's very, 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 very small though, right? So we don't prescribe tamoxifen to smokers. So if you're actively smoking and taking tamoxifen, your risk of developing a stroke, it's like taking estrogen, like taking the birth control pill over the age of 35 and smoking. High risk of getting a stroke, which is a blood clot. And that's an arterial blood clot. And then, of course, a deep vein blood clot, which obviously we worry about. So the risk still is low with tamoxifen. And of all my patients who I've prescribed tamoxifen to, I've only had 3 patients who have clotted over this, many, many years that I've been prescribing tamoxifen that I'm aware of. And of those, it was recent travel. So it was kind of long flights that puts you at slightly increased risk of having a blood clot. In terms of the relationship with COVID, I mean, I can't really speak to that. I mean, to be honest, this virus has all these different kind of sequelae that can happen, and whether or not that there's no relationship that I'm aware of tamoxifen leading to a COVID infection or worse complications. I mean, it could be. If you get sick with COVID, you probably, it's very safe to stop your tamoxifen for the 2-3 weeks while you're sick and to restart it, right? This is more of a chronic treatment of estrogen blockade as opposed to, acutely that you have to block the estrogen and that a cancer cell wakes up and starts growing. It doesn't happen that way, right? It's really a slow process. So stopping it for 2 weeks if you do get infection would be safe.
Okay, thank you for that. Here's another question. Everyone's reading a lot of media articles right now, and I guess the New York Times article that ran earlier this week highlighting estrogen and progesterone treatment in men in trial for mitigation of effects of the virus. For those of us taking various forms of estrogen blockers, what potential implications may there be, considering they're both, they are hypothesizing that estrogen and progesterone are protective against more severe forms of the virus?
Yeah, I think, this is all, you need to have better data than kind of Quasimodo data sometimes. But, I think this is all hypothesis generating. Cancer, the prevention of cancer recurrence is significant, right? We know that if you're on anti-estrogen therapy, it does protect you about 40 to 45% relative risk reduction in developing a recurrence of your cancer or a new cancer. So these are big numbers, and this is the reason why you're taking an anti-estrogen medication. If you are practicing physical distancing, washing your hands, doing everything you're supposed to do, your risk of a COVID infection is low. So I think, you really want to focus on doing that, obviously, but also taking your breast cancer treatment. What we do know, and I think the most recent articles that came out that were a bit concerning came from some data from Italy and also some data from China, small numbers, mind you, but cancer patients are at a 5 times higher risk of having a major catastrophic event if they do get a COVID infection. And that has been the whole premise, and we've kind of known that, but that has been the whole premise of us trying to protect our cancer patients. And these are all comers. So it's not breast cancer patients with anti-estrogen therapy. These are all comers, right? You're looking at acute leukemic patients getting chemo, to other cancer patients. So it's a combination, but we are just being very cautious and careful with our cancer patients.
Yeah, that speaks to the importance of the triaging process and the fact that cancers typically grow slowly, so it's much safer to wait a little while than risk a COVID infection.
Yeah, absolutely.
Okay. So here's someone who was recently diagnosed in February and is on hold for surgery due to COVID. Just wondering if there's anything that she should avoid, maybe diet-wise, during this waiting period. Is there any kind of, I think people want to feel like they can do something while they're waiting. Is there any impact in general that diet can have on her diagnosis?
I think, not diet per se, but, once again, we always talk about being mentally happy. It's very hard for individuals because, especially if you're living in a small apartment and you can't really get out, or you're scared to get out because you have to take an elevator or whatever, or you're living with other individuals. But the most important thing, honestly, is try to, if you can, go for a walk, go outside. Physical activity is important. It's good for mental health. And I think those are key ingredients in getting you through all of this. So physical activity, obviously a well-balanced diet. People are always, asking about sugar and other, high fat, ketosis. Is that going to be a cure for my cancer? And there's so much literature out there that it's really hard to determine what is the best. And if there is any credibility to making all these changes. I think a well-balanced diet, exercise, getting out, getting some fresh air, these are all important to life, right? And to,
Yeah.
to every day. And nothing is specifically going to halt a cancer's growth except the true treatment. And so, unless you've been diagnosed with a breast cancer and you're waiting for your surgery, you're probably on an anti-estrogen if that's the case. So continue taking your medication and try to get outside and with a nicer, warmer weather. Obviously, physically distancing yourself, and get out and get some exercise.
It's going to be interesting because I noticed last night, Friday night, kind of the first nice day, May 1st, our street was buzzing with people standing in the street with cocktails and just like talking. So I wonder if, as the world does start to open up, cancer patients are they're nervous about it, excited because it means, things will open up and treatment will open up, but it's kind of a tricky balance.
It's, there's going to be PTSD, so post-traumatic stress from this for sure. And it's going to affect everyone, cancer patients, everyone. And, I think until a vaccine is made available, we are going to be living in a different world, right?
I wanted to ask you about vaccines because, and then I'll get back to some patient questions, but there's such a thing, everyone wants the vaccine. But in this kind of the race to get one out there can also be a danger of kind of bad or incomplete science getting reported, even in reputable medical journals. Is that something we all just need to be calm and know that this is going to take a while for a vaccine, or what are your thoughts on that?
Yeah, I think so. You've probably seen the news, 90 vaccines are being developed. There's a race to develop. I think there's going to be probably many vaccines, not going to be just one vaccine. There's going to be many vaccines that are going to be very effective. But you're right. I think, so it's right now being clinically tested. So you're looking at antibody production, you're looking at safety. But remember, any medication, the longer the medication's out, the more data or pharmacovigilance that we actually can obtain from that. So we have to trust that the safety will be there and that it will be effective, knowing that continued, ongoing data will be collected to ensure ongoing safety and effect of the vaccines. It's quite incredible. These take, you've heard, 12 to 18 months on average, and that's rapid. This is kind of unprecedented. And don't forget, a lot more knowledge in terms of vaccine development, way more knowledge. So you can imagine all these companies are now just honed in and using all the resources to get a COVID vaccine, as opposed to, working on it a little bit here, now all the energies are moved in. So that's why it's truly unprecedented that we will get a vaccine. It will come, or they will come, the vaccines will come, which will provide, I think, a lot more safety and immunity to, the herd immunity, as you heard, more people immune to it. We can slowly get rid of this virus, I hope. I don't know. It might mutate, but, it's going to be like the influenza probably.
Yeah. Thank you. Okay, here's another question from someone. Okay, so I don't know if you've heard of this, Christine, but there's kind of a little campaign that's out there on social media called Feel It on the First, and it's for women to kind of remind their network or their friends to do a breast exam. She says, I'm 6 months out of my treatment. I noticed my breasts feel very different than before. What characteristics should I watch out for? Will I still get seen by doctors, or will I have to wait until COVID is over?
And so once again, it's individualistic for every patient. Your oncologists are there. You can call the oncologist's office and ask to have a conversation with them. Remember, and we see this a lot, post surgery. So a woman who's had a lumpectomy, And then she's had radiation, which affects the breast and the skin. So that breast typically will feel very different than the normal breast. And I would say radiation is a gift that keeps on giving. That skin tends to change over time. You might feel a firm scar at the site of the incision, and that's common. But obviously, if you notice skin changes that are concerning to you, pain, pain can always be there, to be honest, because when they take that tumor out, they're slicing through nerves. You might start having shooting pains like that, like electric shocks. That's typically your nerves growing back. But if you are concerned, please contact your oncologist, because, we're here. We're still seeing patients, and we, if it can be done virtually, but we are bringing patients in if we have to see them, or contact your surgeon.
Okay. Yeah, I think the surgeons are probably, they're used to being so busy, they're not doing surgeries. So yeah, that's a good one. Okay, another question that kind of goes back to our vaccine conversation. If there is a vaccine for COVID-19, would cancer patients be one of the first to get it, or would it be delayed until treatment is complete?
So cancer, what we do when the flu, so in October, there's enough evidence to show that cancer patients don't need to wait to get the vaccination. They can do it while they're on treatment. And many times when I used to be at St. Mike's, we would have our campaign that we would give the flu vaccine to all our patients while they're coming in for their treatment. So there's enough safety from the flu vaccine to have it during treatment. And I would anticipate that the COVID vaccine will be the same.
Okay, thank you for that. Okay, so I think we've kind of covered a lot about COVID and cancer treatment. Maybe we'll bring forward a few questions that are just kind of about breast cancer and being a young woman with breast cancer. So someone has a specific question. What suggestions would you advise for a triple negative 4-year survivor with both PRIP1, I haven't even heard of that one, and CHEK2 gene mutations, specifically around future scanning or prophylactic mastectomy? So what suggestions would you have with someone?
Yeah, so it depends if it's a patho. So these CHEK2, so now we're doing, when we look at multi-gene, we're looking at multi-gene panels now when we do BRCA. So initially it was only BRCA1, BRCA2, which are the genes, the germline genes that can lead to increased risk of breast cancer. Now we've run a panel of 20 genes. And so CHEK2 is one of them. PALB2 is another one. Maybe that's PALB that was requested or asked.
Yeah, maybe that's a typo because I've not heard of that.
Yeah, so in terms of our higher risk women or higher risk patients, we are, when we start opening up our mammogram MRI, because the mammogram breast MRI are done kind of on this pretty much same time, that those are going to be the first ones that are, as we just actually had a meeting last week, as we're phasing in reopening our breast screening or mammogram suite. Those are going to be the patients that will be triaged in first. So these are the patients that we are going to try to coordinate. Obviously the breast MRI, which is a bit difficult. Mammogram is a lot easier, but it's going to coordinate the breast MRI. In terms of mastectomies, BRCA1, BRCA2 are really the ones that we discuss having a mastectomy for, and bilateral oophorectomies are taking the ovaries out once you've passed childbearing years. It all depends. So it all depends if it's a pathogenic mutation, because sometimes you'll get these mutations that really, it's a coincidence that you had a breast cancer and you have this mutation, because we call it variant of unknown significance, because we don't know what the clinical significance, is it a driver mutation or not? So once again, it's, really looking at which mutation it is and whether or not it's significant.
This patient did let us know that that is accurate. It's BRIP1. BRIP1. So maybe it's BRIP.
Oh, yeah, Brett. Okay, that's good. That's I'd have to, that's not a very common, that's not a very common mutation. And whether or not it's of significance, that have to be looked at. Going back to mastectomies, I think there's been a big push for mastectomies because, this is a disease of the breast, and women who have had a breast cancer don't want to go through this again, don't want to go through surgery, don't want to go through mammograms, don't want to go through chemotherapy if they've received chemotherapy, and it's scary. But remember, if it is a small tumor and you don't have a BRCA B or C mutation, mastectomies are not, we don't recommend mastectomies. We don't recommend amputating the breast. It's an organ, right?
Amputating the healthy breast.
Yeah, we do not recommend amputating the healthy breast. And women who have undergone bilateral mastectomies, it's just, there is pain associated with it. It's a surgery. Even if you're reconstructed, if you're lucky, you can have wonderful reconstructions, and I've seen some amazing reconstructions. But also, there's other issues of having surgery when you don't necessarily have to have surgery.
Makes sense. Here's one more question. Every ache and symptom I'm getting, I'm scared my cancer may have returned, which is a very common fear of our community. I've been having rashes on my back and neck that's been coming back kind of on and off. I was wondering if this is a sign of skin cancer or a different type of cancer. She does have mild eczema as well. Also been having some odd back pain, and maybe she's got a little bit of humor. Maybe it's because of all these Zoom seminars she's been attending, which I definitely know my neck is feeling it. I typically work on my dining room table on not a good chair and laptop. So
yeah, I think, obviously when you've undergone breast cancer treatment, it is totally natural that any new ache and pain, you're going to think, is this my cancer coming back? Or if I have metastatic breast cancer, is my cancer progressing? I always worry about, as an oncologist, about new onset back pain or bony pain. So I do worry about that for patients. We tend to obviously examine patients and arrange a bone scan if it's something concerning. But aches and pains, if you're doing something and all of a sudden your shoulder hurts, or you're getting cramps, or rashes typically are not breast cancer. So and if you already have a skin condition like eczema, you are probably going to be more prone. And don't forget, this is a stressful time for everyone, and if depends on how if you're having new detergents, or if you're staying inside. You've changed the way you live your life. And so, you can have flares of eczema, not to minimize anything though. So if there is always a concern, a new breast, skin changes on your affected breast, that's something that needs to be looked at, like new lesions appearing, really sharp, different kind of new onset bone pain. These are a little bit more concerning that I would certainly contact your oncologist.
Okay. Thank you for that. Another woman's asking, is it safe for me to take any estrogen type pills to help with menopause side effects due to a preventative surgery, oophorectomy for BRCA2? Her diagnosis was triple negative. So we all know that premature menopause is not fun. Can you take those estrogen pills to help cope with some of the side effects?
So if you don't have breasts, so if you've had a bilateral mastectomy because you have the BRCA mutation, I would, and you're waiting for oophorectomy, so your ovaries are probably still functioning unless you had chemo and you've gone into an early menopause. There are other types of medications for your hot flashes besides estrogen. You know, there is so multiple different medications that we try besides taking estrogen. Now, you're asking, I had a triple negative breast cancer. What is my risk of taking estrogen because I didn't have an estrogen-driven tumor? You know, if you still have breasts, there is still a risk of developing breast cancer. And that breast cancer can be estrogen-driven, right? So we have ER-positive breast cancers, estrogen receptor positive breast cancers in BRCA mutation carriers, germline BRCA mutation carriers. So that's why we're a bit cautious to taking systemic estrogen. So either taking the patch or a pill. For vaginal health, so women who have vaginal dryness, sexual dysfunction, pain, ongoing vaginal issues, because of taking anti-estrogen medication, you know, there's research, we're actually embarking on a good research project looking at whether or not low dose topical estrogen around the vagina would benefit patients. Whereas the absorption of that is extremely, extremely low. But once again, we're looking at a clinical study to answer that for our women who are taking anti-estrogen medication. So systemically, anti-estrogen is blocked and is blocked obviously everywhere. And so trying to minimize the side effects. Obviously the best is lubrication and all of that.
Yeah, okay, thank you for that. Speaking of side effects, someone's asked a question. I constantly feel like I have creepy crawlies on me, mostly on my neck. She's on Herceptin, Perjeta, tamoxifen, and Zoladex. Is that creepy crawly neck feeling a side effect of these medications? It's kind of like a...
Yeah, no, it can be for sure. I've noticed in some of my patients, now it all depends. It could be a drug reaction, right? So it's try to tease out, you're on a lot of different medications, whether or not it's the Herceptin or the Perjeta or the tamoxifen. Typically, tamoxifen tends to be the culprit. That being said, there are different generic forms of tamoxifen, so you might want to see which one you're on and whether or not it can be switched. So if you're on a Tiva versus an APO versus a Sandoz, there's a lot of different tamoxifens out there. There was a tamoxifen shortage before, as you're all probably aware. So just seeing which tamoxifen brand that you're on, and maybe that can be switched out. Alternatively, you can stop the tamoxifen for 2 weeks safely and see whether or not the creepy crawlies disappear, and do a little experiment and see truly if it is the tamoxifen. Because you know, before you start asking for a different brand, you might want to do that.
Okay, another related tamoxifen question. Would you recommend tamoxifen for someone with low levels of ER and PR? So ER is 10% and PR is only 1%. Is that...
I mean, that's a good question. We have a few patients like this where, you know, the ER is very low. Back in the day, in the olden days, the cutoff was 10%. That's still a very small percentage. So that's preventing that specific breast cancer from coming back. Tamoxifen also will prevent other breast cancers from developing. So remember that there is that small benefit, that 40% to 45% relative risk reduction of developing a contralateral breast cancer, so on the opposite breast. That being said, I mean, that tumor can be re-reviewed, right? You can ask for a pathology review because sometimes you have different tests, so different antibodies used to look at the estrogen receptor, and sometimes they are super sensitive. But ER 10%, we still, if you can tolerate the tamoxifen, we do still recommend.
Yeah, okay. Another question. Can you talk about abbreviated breast MRI versus mammography for US or all three as good follow-up for future prevention post like someone's using shorthand.
Ultrasound. US is ultrasound.
Okay, for good follow-up for future prevention post lumpectomy, chemo, radiation, and currently on Arimidex long-term, grade 3, stage 2A tumor with onco 30 plus previously. Suggestions for food to remove from diet for ER/PR positive HER2 negative patient. I don't know if that's the same question.
So for surveillance, for follow-up, mammograms are, now that we get tomosynthesis mammograms, those are the best. Very different than MRI. So the difference, and people think, oh, I need to have an MRI and an ultrasound and a mammogram. Mammograms are truly the best in picking up microcalcifications. So what is that? So mammogram literally is an X-ray, right? It's an X-ray of your breast. And on the X-ray, you're going to see dots. And those dots are what we're looking for. Those are called microcalcifications, because that's where the breast cancer begins, right? So you've heard of ductal carcinoma in situ. These are pre-cancers. They're not invasive cancers, they're pre-cancers. That's why our survivals are so much better. Cure rates are so much better because mammograms are picking up these early pre-breast cancers that left alone will develop into a breast cancer. MRI cannot pick up microcalcifications. MRIs are not X-rays, and MRIs do pick up a lot of other stuff. I can't tell you every time we have a tumor board, if someone's had a breast MRI, because they've had a breast, there's a new diagnosis of breast cancer, and we've done a breast MRI to further delineate that breast cancer, other things starts popping up on either that breast or the opposite breast, leading us to do a lot of biopsies, sticking needles, and most of the time they're negative, right? So MRI will pick up a lot of noise. And the last thing is ultrasound. Ultrasound is great if there already is kind of a mass there, or if there are microcalcifications already seen on the mammogram. So you will have, if there is an abnormality or microcalcification seen on a mammogram, you will then have an ultrasound guided biopsy, and that will be looking at whether or not there's any mass or abnormality within that breast. So mammograms, and they've become much better, are really the best modality of picking up early breast cancer.
I've had 2 MRI guided biopsies, and someday I'll write about it because it's a very strange, bizarre experience.
Yeah, and that's
out there and had one.
Yeah, so MRI guided biopsies, because it probably was never seen on an ultrasound. So this is the big issue, right? So these are small, probably abnormalities, and you'll see them 3 to 6 month follow up, right? So 6 month follow up is to see, is this nothing? Because if it's nothing, it's probably going to be nothing, and if it grows, then we can certainly then go after it.
Thank you. We've got, I'm going to take 2 more questions. Here's one we have. I was wondering, I was supposed to have a bilateral mastectomy, but due to COVID, they will only do a unilateral mastectomy. Once the restrictions have been lifted, would they be able to do the other elective side? I have triple negative breast cancer. Oops.
Yeah, so I think that all depends on what is being offered in terms of reconstruction as well, right? So if this is a surgical clearance of the tumor, and the reason why they're doing one is because of OR time and complexity probably of the case, and for safety of you, of the patient. If you're going to be reconstructed, they probably will then wait afterwards, so probably a year. I don't know, typically women will wait 6 to 12 months, then have the opposite breast removed. Unless you're a BRCA mutation carrier, that is why you would be recommended. If you're not, then I still don't know why you're having a mastectomy on the healthy breast, an unaffected breast. But if you are a BRCA mutation carrier, then it is recommended for the bilateral mastectomy. If you've had your curative lumpectomy already on that breast, then you should wait until you probably have both at the same time and reconstruct it at the same time. But if that is a curative surgery for your current breast cancer today, and you're being looked for a mastectomy, then you're going to only have probably one and wait to be reconstructed.
Okay. One last question. Is it true that testing for your recurrence score and CA153 markers, etc., is not standard in Toronto? Is there a potential for these tests to become standard? I know in the US, their tests are standard. So our community, because of social media, women can connect with patients all over the world. And often we have quite a lot of American followers. So different treatments get discussed, different tests, different things.
Sure. So in terms of biomarkers, so cancer biomarkers, the ones that we use for breast cancer when it's in the metastatic setting, and the advanced setting is CEA and CA15-3. So those are the two that we commonly use. Now, every oncologist is different. I use biomarkers. I find that it just gives me and the patient, that it gives us more information in terms of making treatment decisions together. So, for example, if you have metastatic breast cancer only to bone, there's no reason to be scanning you all the time with a CT scan. Now in the US, they probably use PET scans more often. But remember, that's radiation, right? That's extra radiation that if your disease is stable. So if you have only bone-only disease, so say you have a couple of spots in the spine, which are small, and you're on good anti-estrogen therapy, for example, I will use, obviously, see you and how your symptoms are doing, but also use the tumor markers. So if they're elevated and they start coming down with treatment, it gives us kind of good information, right? If those tumor markers start then creeping up, then we can then push for scans and see if things are changing. So it guides us a little bit in terms of treatment, but they are used in Canada for metastatic disease. They're not used for curative because really there's no strong evidence to support it. We don't scan patients with full body CT scans in the curative survivorship phase. We tend to really just advocate for the annual mammogram and see how patients are doing.
Okay, squeezing in one more question before we let you go. Any comment on foods to omit if you're ER, PR positive? Soya, flax, those kind of things.
Yeah, I mean, everything is in moderation, right? I mean, if I'm not a soy fan, but anyways, if you're a guy, I just don't like the taste of it. But some women love soy, right? So, I mean, obviously in moderation. If you have an ER-positive breast cancer, you are probably on anti-estrogen therapy anyway. So you're already blocking kind of endogenous estrogen anyways. So the phytoestrogens coming off of soy, whether or not that leads to competition hasn't really been well established. I think everything in moderation is important, and to continue, if you can, your anti-estrogen treatment. That is the most important. Vitamin D, make sure vitamin D 2000 to help supplement your bone health. And another thing is like calcium. Be careful with the calcium-enriched diet in terms of making sure you have enough calcium, obviously, for your bone health. But not necessarily taking a lot more calcium than needed, because it can lead to kidney stones and other constipation, other things.
Thank you so much for that. I just want to give you a really big heartfelt thank you for coming on this Zoom with us. We know how busy you are, and we just so happy that you could be here to chat with us today, and for taking the time of your weekend. And we think it's just so amazing. And just to close off, I want to give a thank you to some of our sponsors. So when all of this started, we quickly put out feelers to some of our partners who've been supporters and asked for a little bit extra, because our patients need extra support right now. Our community needs extra support. So a shout out to Roche, Pfizer Canada, Eli Lilly, Eisai, AstraZeneca, Amgen, Novartis, and most recently Mackenzie Investments for making some of this COVID response programming possible. So thank you Dr. Brezden-Masley, thank you all of you for joining and being here with your great questions. And I'm just so happy we didn't have any technical issues. Yay, we're all pros at Zoom now. And everyone have a great weekend. And we're going to be doing more of these. And just thank you to everyone.
And virtual hugs to everybody.
Okay, thank you.
Bye.
Bye.